Welcome back to the next session, which is why data collection, publication, and use matters for public health prevention. This session will explore the technologically positions across Europe for immunization information systems with a focus on cancer use cases, the data challenges involved with vaccine hesitancy and misinformation, and why this matters for the public. The panel includes a clinician, a researcher, a technologist, and a patient advocate, so a broad spectrum of perspectives. The previous cancer panel was highlighting how to best treat cancer. This session will look at how to prevent cancer. So the format is going to be quick introductions from each of the panelists, then four short presentations, followed by a panel discussion. So I'm going to ask each person to introduce themselves, starting with William.
Hi, Bledden. Great to see you again. I'm William Flanagan. I'm a director and co-founder with OpenSky Data Systems. We're a technology consulting firm. We've been around since 2004, solving complex business challenges for enterprise organizations through data intelligence and AI. I've been working in the health and life science area myself, among other things, for about the last 15 to 20 years with developing immunization vaccination registry solutions for the Irish government and working with partners like MSD and other organizations in tracking vaccine coverage rates across other markets within Europe. And looking forward to joining this panel.
Thanks. Trenton.
Hi, Trenton White. I'm a researcher at the Barcelona Institute for Global Health, where I focus on health systems services research for infectious diseases. I come from a background of global health and development, previously at the World Bank, where I worked on immunization systems and financing for those systems, as well as the U.S. Agency for International Development, where I was primarily responsible for development projects on pandemic preparedness and response and recovery.
Great, thank you. Marius.
Hello, everybody. I'm Marius Janta. I'm a medical doctor by training. I'm specializing in public health, and I have a PhD on large language models and the emerging role on cancer literacy. I'm the founder of the Center for Innovation in Medicine. I'm based here in Bucharest, but very active at European level in different topics around cancer, and in particular, cancer mission. And I was part of the working group for the National Cancer Control Plan here in Romania.
Thank you. And then lastly, but not least, Richard.
Hello, good morning, everybody. My name is Richard Price. I'm the head of policy at the European Cancer Organization. We're an umbrella federation of 41 primarily healthcare professional organizations working in cancer care, and we have a founding mission of 40 years standing, which is to try and improve patient outcomes through multidisciplinarity and multi-professionalism. And it won't surprise anyone to know that in order to do that, we need to collect, use, publish good quality data in whatever field that we're trying to improve. So it's fantastic to join you for this particular discussion today.
Thank you very much. And if we can share my slides now, please. Slight pause. These slides are the roundtable slides for the immunization information systems that we ran. Okay, I think I've got them. Sorry, bear with me. Right, so very quickly, just talking about the importance and urgency of this topic, very much driven by the pandemic and the need for real-time interoperable data, as well as the cross-border collaboration illustrated by the COVID certificate. And also on that page, just highlight very quickly the aggregated data intelligence. In terms of the urgency, so I'm just going to pick this up. There's some cases around immunization, use cases, as well as then recommendations, but moving us along. The sort of priority cases I wanted just to highlight was the linking vaccination coverage to disease burden, linking outbreaks to vaccination coverage gaps, and then linking campaigns to vaccination update. And then in terms of the use cases, the report was pushing out the distinction between person-specific uses, population uses, and program uses. But I'm not going to talk in any detail about any of those. So the highest priority recommendation was asking the European Commission to use immunization as a focus for the One Health mission. And then looking to some of the other priorities, this was very much about wanting to see presidencies take up immunization as part of things that they would champion during their presidency. And then turning again to the need for international cooperation across multi-stakeholders, being led to look at interoperability standards, data quality standards, as well as coordinating, recognizing that records were sometimes in very different places, i.e. school records. And then asking the European Commission to advance immunization as part of EHDS and seeing perhaps almost like an immunization space being developed. So we called on DG Health and DG Connect to lead this multi-stakeholder engagement. And I don't think in terms of the strongly endorsed factors, this is about trust, but also inevitably trust in the vaccination itself. And I'm sure that these will come up in the discussions that we have during this panel. So with that, I'm going to hand over to William to start us off.
Great, thank you, Bledan. So I may need your assistance in moving the slides because I'm not seeing the arrow there. So perhaps I'll ask you guys to help us. Okay, so thanks very much for the introduction, Bledan, and following on from what you were talking about there, I'd like to give a short presentation here on a piece of research that OpenSky did in collaboration with our friends at ECH Alliance and MSD, which was to look into the state of the art of electronic vaccination registries, initially in Europe and subsequently in Asia Pacific, excuse me. Perhaps we'll move on to the next slide there. So, I'm seeing that. Okay, I've got the arrows now.
Okay, good.
There we go. Okay, so we wanted to map the state of the art of electronic vaccination registries. And this was very much post-COVID, where we saw, an incredible acceleration and momentum in terms of tracking COVID vaccination rates and technology being deployed rapidly. And then we wanted to know, well, for things like HPV and related preventable cancers and so on, can we learn any lessons from that? And in terms of broader vaccinations and capitalize on that momentum. So we were looking to identify best-in-class EVRs, electronic vaccination registries, and ones that subsequent to that are delivering good quality VCR information, vaccination coverage rates information, and then to try and spot the divides to come up with scoring mechanisms for that in these territories, spot the divides between those and identify issues and how we might overcome the differences between those. So we, just in terms of methodology, so we defined our data mapping parameters, and there's certain qualities and so on that we were looking for within the vaccination registries, not specifically just pertaining to vaccination, for example, but also, Bledan, you're mentioning things there like interoperability, which for vaccines that relate to preventable cancers, for example, it's very important that we have interoperability with things like screening registries or cancer registries and so on. So to do the work, we then did a suite of interviews and desk-based research across the region, and devised the scoring algorithm based on a suite of data capture points across the entirety of those territories, and from there developed that reporting and heat map. So what did we find? So if we look first at the state of the art in European territories, it's probably, for people familiar with the space, it wasn't a huge surprise to see what we saw here, which was in the Nordics. We saw very much the best in class within Europe, where they had the strongest and probably longest standing EVRs that were integrated with things like electronic health registries that were publishing at a relatively frequent basis vaccination coverage rates for pretty much everything that might be in the National Immunisation Plan. And as we moved, we'll say, west to the United Kingdom and Ireland, we saw slightly lower, but again, strong standards. But as we moved further south, we started to see differing standards, and then further to the east as well, where in some cases there wasn't electronic vaccination registries at all, where there may have been previously attempts of putting in EHR solutions that just didn't succeed very well, and as such, didn't lead to integrated EVRs and so on. Now there's a whole range of different things going on there, but again, we did find that the best in class was coming from the Nordics regions. So what were the things that we found? So there was quite a lot of variations in the use of ICT, comparing south, west, north, east, and so on. And we did see a correlation between vaccination coverage rates as published and the quality of the electronic vaccination registries themselves. And I would say correlation in that regard. And we did feel that looking at where the areas of best practice were, that if we can harness some of those common approaches to EVRs, that would make a strong difference across Europe. But there are challenges to that, obviously, because there's significant variations to electronic vaccination registries where they exist. And influence, when we're trying to have a pan-European approach to these things, it can be difficult to get to bring influence to bear against various different countries. And obviously then there's a suite of constraints that apply here, both technological, but also in terms of adopting the technologies, rolling them out, legislative constraints that might underpin those. So learnings and recommendations. So we feel, found that the existence and the relevance of the EVRs are really important for higher VCR and tracking rates. Again, if we're not tracking the vaccination coverage rate, how can we tell, or how can we monitor the success of our vaccination policies and our NIPs and so on? We did find across all the territories that we were looking at that there was the will to increase vaccination coverage rates and a significant investment within that. And within all countries, there was an attempt to put ICT solutions in place for that, but again, a significant variety in terms of quality across that. There can be a variety of different reasons as to why there wasn't more traction in terms of that. Sometimes it's inertia. It's the technology can be part of the challenge, as I said, but again, it's not easy to take a piece of technology and apply it across a complete country. We'll probably talk a bit later about European health data space, and that's something that could offer some key opportunities here for this, because interoperability is becoming a hotter and hotter topic within the EU. And for this data to be interoperable and shareable at an EU level, things like common templates and minimum data sets would be really strong add here in terms of interoperability going forward. So subsequent to the research that we did in Europe, we took the identical methodology and applied this to Asia Pacific. So as you can see, both territories are mapped on this particular heat map here now. Again, given what we saw in Europe, what in terms of the findings here, a lot of them were actually not surprising, in the sense that the high income countries like Australia, New Zealand, Taiwan, and Korea did have generally more established EVRs, and they were integrated into the broader health systems within those countries. The higher population countries like China and India had other challenges in terms of administrative geographic challenges, and also regional issues, with the federal nature of some of these countries. And we did see challenges around vaccine hesitancy, limited public awareness, and some barriers remaining in places like Japan and Indonesia. We didn't find consistent reporting mechanisms across these countries, and interoperability would have been a very strong thing to bridge data gaps, which was another finding. So in terms of next steps, so we feel that a common virtual common model for the electronic vaccination registry across Europe would be a real value add in terms of setting a direction and a guidance for countries within Europe. To assess the drivers and barriers within particular country levels, and I can say from my own experience, these are really broad, significant and broad swathe of issues that apply in a market or country by country basis. No one country is the same to the next one, and with things that would be of huge benefit for things like preventable cancers like cervical cancer, for example, is the integration with cancer and screening registries, and specifically the integration with e-health records, which gives other benefits such as vaccine passports and other things as well. So, and then we'd like to have more regions mapped as well. So we've done this for Europe and for Asia. It would be great to move on with this methodology to Latin America, North America, and Africa. Again, you mentioned at the beginning there the different levels that this is really important for, both at the individual level for tracking their own status, at the population level for tracking the progress of public health and public health policies and interventions and so on, and then at the federal or intergovernmental level for sharing information across the EU. And we know that the European Council have made recommendations here and would like to see a standard dashboard across the European Union for vaccination against preventable diseases. And I think as well, and again, this is secondary usage of data, for example, in places like the European Health Data Space, where this data is of huge value, where if you can track vaccination coverage rates and trends, and that you can see how that is relating to things like again, occurrences of cancer or screening, or socioeconomic or demographic trends, and to actually try and use that information to inform policy at individual country level and at the broader EU level. I think one of the key things here is that in terms of public confidence as well, it's very important for countries to be actually able to share this data, put it out in the public domain, for not just for the likes of academia and for people who are going to use this for research purposes, but also for confidence of the public, the broader public, in actually seeing that there's transparency and that they can understand where the vaccines are and where they're being used and what the uptake is as well.
Okay. Fantastic.
And I'm going to finish up there. Yeah, that's my last slide. Thanks, Bledin.
Brilliant, thanks. Whilst we put Marius's slides on, one quick thing. If you want to access William and Open Skies report, the link is in the chat so that you can study that in more detail. So please do that. So Marius, over to you. Oh no,
I think we'll go to me now, Trenton.
Oh yeah. Okay, sorry.
Quite all right. Thank you, Bledin, and to the rest for organizing. So I'll touch today on several important issues in information systems for immunization. I want to start by an overview of the sources of information that health system decision makers have for themselves. So it requires a whole of system perspective when you're a health system decision maker. And often we think of in information systems, that data being fed up from subnational governments, but it also comes from scientists and researchers, tech companies, medias, and so on. And this is not an exhaustive list by any means, but I want to focus today on inputs that are coming from the public and from individuals themselves, because understanding the public perception can inform our response efforts to things like immunization campaigns and during the pandemic, social measures. And of course, this perception can be influenced by a variety of factors. These data come from a series of studies that we did during the pandemic on acceptance of a COVID-19 vaccine in 23 countries with representative samples from each country. And we see here a steady increase in confidence in the COVID-19 vaccine, despite misinformation and disinformation at the same time. But what was worrying in the final year of our study is that as a result of their COVID-19 experience, the pandemic experience, only 61% were willing to vaccinate against other diseases. And we saw this in data from UNICEF and others that showed a lower coverage rate in things like measles, mumps, rubella, etc. And this was even more worrying when we looked at this issue from a variety of healthcare providers. So we saw that about 15% of healthcare providers globally displayed some sort of hesitancy against a vaccine, whereas 4% outright rejected taking a vaccine. Physicians exhibited the lowest amount of hesitancy, and the factors for hesitancy were having a lower income, younger age, concerns with safety and efficacy, as well as mistrust in the science behind the vaccine and the perception of inequity in distribution. And this is important because consistently healthcare providers are ranked as the most trusted sources of any health information, but also vaccine health information. And it's important as well from an information system to discuss the infodemic. This is largely a world we live in now, because information systems that have public inputs, information coming from the public themselves, will inherently be impacted by infodemics, which simply refers to a large volume and rapid velocity of information, whether it's true or not, in a digitized world, excuse me. This presents challenges that make it, such as making it difficult for people to assess truth from falsehoods themselves, as well as we saw with COVID, difficulty for the scientific community to stay on top of publication and accurate information in order to provide health officials with correct information. But the WHO has developed a framework for monitoring the infodemic and managing the infodemic. This begins with monitoring in real time information about the health emergency that we're dealing with. Second, detecting narratives that emerge, especially false ones, to be able to combat them. Intervening with effective risk communication strategies, and then strengthening the infodemic management system in a circular fashion so that we're constantly evaluating its effectiveness and partnering with trusted community leaders. So I'll touch briefly on each one of these steps. And the first, social listening has become one of the gold standard techniques for monitoring health information. It simply refers to monitoring publicly shared information, both online and offline, on a topic of interest. In COVID-19, we did look at vaccines and social measures. And this is in order to understand the target population's needs, concerns, and challenges around these topics. Second and third, I wanted to bring up these vaccination personas developed by the Vaccine Competence Project, as well as UNICEF, which were developed through a social listening exercise in Europe and Central Asia. And it's tended to capture broad behavioral tendencies in order to inform vaccine campaigns and vaccination campaigns through communication materials. So for example, if someone was both dutiful and rational, they exhibited traits of being compliant, respectful of their in-group, and following authority inherently, where somebody who was rational and anti-authority may be more challenging, of course, of authority, and philosophical or analytical in their approach to vaccination. And so you can begin to see how you would develop different communication strategies based on one's vaccination persona, which we might not get just by looking at age, sex, gender, or age, gender, race, etc., which is how we often like to cross-tab the type of data we receive. Finally, and I wanted to bring this behavior and social drivers model of vaccination up because it's a good one to strengthen data collection, both in terms of quality and the amount of data that we receive across this entire model. So on the very far right side in vaccination, this is where many countries are quite good at measuring uptake of vaccines, though not all. There's certainly room for improvement. And then here in the center, motivation in the pink box, this is intention to vaccinate or confidence of vaccination, where in research we have generally good methodologies for eliciting this information, though it's not always integrated into immunization information systems. Between these two are the health system functions, the practical issues such as availability, affordability, accessibility, and then the type of service, quality service that one receives from healthcare workers, where I've seen this type of data collected such as through supply chains and development projects, but rarely if ever, is it integrated into immunization information systems. And then on the far left, the thinking and feeling and social processes boxes, how people view vaccines, their own risk, what people around them are saying. This type of information is rarely, if ever, collected even in research, and it's a developing field of research in order to understand in a more targeted sense to be able to target populations. So thank you.
Trent, thank you very much indeed. Can we pull up Marius's slides now, please? It is your turn this time.
Yes, thank you. Thank you very much, Bledin, and I'm very happy to be here today and to share some data from one of the projects we are part of, called the Rethink HPV project. So hopefully I can see my slides on the screen.
I think they're coming.
Yeah. So Rethink HPV vaccination is a project is funded under the EU for Health, and this project it's a very important one in order to understand what is happening actually with the HPV vaccination in my home country, in Romania, and based on what we developed in the project so far, hopefully we'll be able to influence the way the vaccination is done in Eastern Europe. So we have been influenced by the developments during the pandemic, and we all know that at the European level, the COVID-19 vaccine was available for all the countries the same day, But after 1 year and 2 years, we can see major differences in terms of the uptake. And we call this phenomenon like an iron curtain when it comes to vaccination in Europe. So the vaccination rate in Eastern Europe is around, in Romania, is around 40% for COVID-19 vaccination with 2 doses, compared with 80-90%, maybe more in Western European countries. So having this in mind, we put forward an application for a project on HPV vaccination, and the consortium consists of 3 organizations from my country, from Romania, and the idea was to look to the social and individual determinants of vaccination based on the experience of the COVID-19 vaccination, and to try to understand what is actually happening at societal level and how these strategies can be informed by other types of data than the current data we are used to work with in the public health domain. We experience actually this year in Romania the highest interest of all times when it comes to HPV vaccination. So the data are coming from the Google Trends. In the red arrow is coming from 2008. The interest was very high, but from a totally different reason, was a political scandal who accompanied the first vaccination campaign for HPV vaccination. So it was a big scandal at that time, and basically the first campaign for HPV vaccination failed in my country. And as you can see, the interest was lower and lower and lower. Now it's very high because of many initiatives around HPV vaccination, some of the activities coming from our government in the frame of the Euro-Splitting Cancer Plan, from the groups like ours, and as well ECO has a program on HPV vaccination involving my country. But despite this interest of the population, a very high one, actually we didn't succeed to vaccinate too many people actually in Romania. And we consume around 10,000 doses per month. And this is actually very, very low. And probably one of the reasons for this is that in this equation of how to best implement HPV vaccination campaign, we are not looking to all the relevant data. And coming to the public health training I done more than 10 years ago, it's always for me a very strong argument to show this picture. And if we would put together the individual behavior and social factors, you can see that actually 60% of the health determinants are outside of the health system and outside of the biomedical data. And this type of data related to individuals and population are not part of the strategies, are not part of our current discussion. So this was the justification, the reason we put forward this project on HPV vaccination. Another pillar in the project is the we call this personalized communication matrix for HPV vaccination, and the idea is that each of us is surrounded by a micro level, family members, very, very close friends who are part of our daily decisions and daily life. Then is the meso level, and this is in particular relevant for people living in villages, in small towns, but for our topic of interest might be family doctors or educators or professors in the school, and is the macro level, the informational space. And this is the space where the fake news and disinformation and misinformation play a role. So in order to deliver the right message at the right time to the right person when it comes to HPV vaccination, we should be able to map the 3 levels that I mentioned, micro and meso and macro level, from an individual behavioral and societal, social point of view, in addition to the data that are generated from a biomedical biomedical field and data related to the health system. And so applying this in our project, we actually being able to identify at least 7 distinct groups at the population in Romania when it comes to HPV vaccination. And as you can see, the groups are very well defined, from well-informed and pro-vaccination groups to uninformed or indifferent group. Then is the third, parents of minors. The fourth group, healthcare reliant group. The fifth, socioeconomical challenge group. The sixth, skeptical or safety concern group. And the seventh, anti-vaxxers. So in other words, if you consider to implement a HPV vaccination campaign, you should actually address at least each of these groups, and to try to, first of all, to go deeper and deeper to understand the reasons why the people are not informed, just to consider the second group, or why they are not interested on this, and then to come with the right message in order to inform them. And this is the way to deal in a vaccination campaign. So probably we are now in a position where we probably reach the potential of the first group in Romania, well-informed and in favor of the vaccination. So these are the people most interested. The vaccine was available and the information was for them available. And then we should change actually the narratives and the implementation of the vaccination campaign, and to go to the other groups in order to increase the vaccination uptake. So the first phase in our approach was to collect these data using different social sciences tools, and of course to put these data together with data coming from biomedical field, especially data related to the efficiency and safety of the vaccination and coverage in other countries and so on. The second phase was the stratification, and I already presented these at least seven groups we identified. And now, especially in this context of large language models, I think this is a great opportunity to think how to move forward and to use LLMs and the data generated in order to apply this personalized communication model even more efficiently, ideally to go at the individual level. But the message is to be really tailored based on all these data. To put this in a slightly different image, it's like moving from one size fits all. This was something from 2008, the first campaign in Romania. I'm sure that we are now moving towards a pret-a-porter approach, and hopefully with the AI and large language models, we will be in the position to speak about the haute couture approach to HPV vaccination. So thank you very much.
Marius, thank you very much. And let's move quickly on to Richard.
Hi, everybody. Well, as mentioned in my opening remarks, we have a very wide brief at the European Cancer Organization in terms of improving patient outcomes through multidisciplinarity. So we segment our work through a number of networks, which people are welcome to join and be part of. And those look at things like prevention and early detection, quality of cancer care. We have a network dedicated to HPV and HBV cancer elimination, survivorship and quality of life. But a network that sort of impacts all of them and sits through them all is our network on digital health. And really, we make no apologies at the European Cancer Organization. We're kind of evangelical about what we think digital data, AI can do to potentially revolutionize how we do cancer control and cancer care. Issues like ensuring that we can be better at detecting cancers, that we're seeing fantastic sort of interesting use of chatbots to help people perhaps improve their lifestyles and manage cancer risk, improve treatment strategies, improve research, and of course improve the information that we have in fields like vaccination. So with that brief, we've been very involved as an organisation in promoting the needs of the cancer sector in respect to things like the European Health Data Space, which is now moving towards implementation. We think that has great potential in many areas, and it was great to see in the Open Sky report that issue very much picked up on. The things that we were promoting in that context were needs for interoperability between registries across Europe, and that's been a call for a long time, but it needs targets, it needs accountability and scrutiny, and we think the health data space is one way to do that. And of course, something else that holds things back is the issue of funding. In terms of the role of the European Union in this field, we see health data infrastructures as really on a parallel with road and rail infrastructure in the modern age. These things are critical for the operation of public services, but also for modern economies. So directing funding to help countries build their health infrastructures in the context of the health data space is a strong investment to make. Registry information is critical. And of course, the other thing is to make sure that for all of these data initiatives, be it the European Health Data Space or anything else, having the stakeholders involved is critical too. This is, as I'm sure we'll touch on in the discussion, high trust sensitivity when it comes to patient data, and not having patients at the table and other stakeholders runs the risk of creating mistrust, and that's something we can't really afford in the field. In terms of sort of using data to help the efforts on vaccination, perhaps it's worth reminding the audience, politically, the European Union has made a very big commitment, which is with the agreement of all member states, that there is a target to eliminate HPV cancers as part of Europe's Beating Cancer Plan, which is very noble, and if we can be something very celebratory in terms of the European Union success in bringing countries together in health, equivalent to smallpox eradication or polio eradication. But we won't reach those goals without measuring how we're doing. And I think since that goal has been published, I think member states have become more and more alert that our data systems are not strong enough for measuring progress towards that goal. So very notably, earlier this year, under the Belgian presidency of the European Union, member state governments came to an agreement about a set of recommendations on how to achieve the eradication of vaccine preventable cancers. And it's really clear in that document that the member states recognise that the data that we collect across countries now at the moment is currently very fragmented. It's not picking up on the issues that we need to see, such as vaccination of boys or vaccination of young adults, and also that the GDPR is something that member states are saying is a problem sometimes for the collection and sharing of data. So I think at least there's a recognition from countries about those problems. There's also a sense of perhaps giving authority to institutions like the European Centre for Disease Prevention and Control to take more of a role in this field. We have to see how all of this is implemented under the new commission. But all of that is to say that this report from Open Sky comes at a very helpful time, because from my reading of the report, it helps to set out what good looks like for vaccine registries, and that's important. So if we're going to have 27 or more countries improving their vaccine registries, we need reports like this to help shine a light and to stimulate discussion. So congratulations to the authors, and looking forward to the discussion about how we go forward with now that the report is published.
Richard, thank you very much. And those are obviously very important insights from the patient perspective. So let's start our discussion. And I just want to pick up on, first of all, Trenton's point about the drop-off, if you like, in approach or willingness to vaccination post-COVID. And I'm just wondering whether this chimes with the rest of you, and if so, do we have any ideas about how we try and tackle that? So I don't mind who jumps in first.
I reckon I can jump in first since I brought it up. So at the time around, I think 2022, 2023, we did see a drop off globally in routine immunization service coverages, though that started to pick back up. Some of it is attributable to vaccine hesitancy, but a great deal of it was also attributable to vaccine distribution systems and supply chains being disrupted by the pandemic. I think it's very important, something that we should continue working on. Obviously, this is something that I do in my own work, but I'm curious to hear what others think.
Marius.
Indeed, we try to understand what is actually happening in Eastern Europe with the COVID-19 vaccinations. And we work with some social scientists from the region in order to understand this. And because the numbers are quite similar, except Hungary. Hungary is an exception, and it's much closer to Western Europe than the Eastern Europe. And the keyword actually, probably it's an explanation for this, is the trust of the citizens in governments, the trust in the medical establishment, in the health system itself, in medical doctors, and the trust between us. So it's a mix of things. And yeah, we experienced this in Eastern Europe, the same situation. People who started to become hesitant, not just on HP vaccination, but on vaccines that are recommended for many years for kids immunization and so on. The numbers are dropping, and for me it's not a surprise, because if we're not addressing the key issue, who is the trust, and if we'll not restore the trust, will not change this situation.
And I think that, sorry, anyone else want to jump in? Yeah, Richard.
Yeah, I mean, to answer the question of, have we learned the lessons of COVID? I'd say no. We've seen lots of things that maybe were more positive during COVID. We saw reductions in trial bureaucracy, for example. We saw much faster publication of public health information. All of those things seem to have gone back to where we were. Another major area that I don't think we've learned the lessons on is workforce availability. That was a critical part of the crisis, but we don't see that, for example, in the remit of the new EU Health Emergencies and Response Authority. But I want to, in context of this conversation, something that I think a lot of people noted was a positive feature of the EU's response to COVID-19 was the vaccine tracking by the European Centre for Disease Control and Prevention, which was updated almost daily, I think, showing the difference between countries and helping inform policy. Now, we've felt very strongly that that should be replicated for other vaccine areas. These are also critical public health needs, and that's yet to happen. Hopefully it will in the future. But overall, I think we may need some sort of inquiry into how did the European Union respond to COVID? What do we learn? Because I'm a little fearful that we're going to motor on ahead and lose some of those lessons.
And then thinking about the pandemic, one of the things is that I suspect that so many people in so many countries became avid followers of the daily sort of health data that was being published in countries. And it created an awareness of, let's say, health data, the vaccination, the R number, if you like. And I'm just wondering whether, if we looked at health information, immunization systems, whether there's a communication challenge to inform the wider public of the value of these, whether we call them registries or systems for a second, and show the benefits to society of the use of them. Do we think that type of an information campaign would be helpful? And if so, any ideas around whose job that is?
I can't say necessarily whose job it might be, Bladen, but just in terms of the actual concept itself, I was talking to somebody recently about the HPV vaccination and the general kind of concept of, I guess, literacy that you're talking about there. And they were saying about a survey that was done in a particular country where a significant proportion of middle-aged men believed that they'd received the HPV vaccine, which is patently not true because it wasn't available when they were of the age that it could have been applied, you know. So, but, you know, to back to your question, well, how would immunization information systems assist with that? Well, one of them is at the individual level, so that, you know, people can understand from their own records what their vaccination records actually are, which is a starting point of dealing with that at the most basic literacy level, and then informing the public as to, you know, the distribution and the uptake of the vaccines themselves in terms of instilling confidence and an understanding of the rollout of these things. Is transparency, to me, is a hugely important factor as well.
And Richard, I'm going to ask you, do you think that we need a sort of campaign to push immunization information systems as a priority for EHDS?
Oh, I think so. I think, you know, there's the high value that can be returned from doing that. And I think, you know, what's much needed with, I think, the European Health Data Space is sort of making it tangible and directing it towards a goal. So we've got the member states through those vaccine preventable cancers recommendations wanting something of this nature. We've got the need for priority use cases for the health data system. So everything would seem quite well aligned in that respect. And just on the former point as well about sort of data literacy, I think, yes, that's critical in the sort of environment of mistrust and things that we have, that citizens understand the data that they're provided with. But I also think data can be quite, if well used, motivating, not only for the public health community, but for broad citizens as well, to see we're moving towards an elimination goal. I think that's going to get a lot of buy-in from others too. So in terms of who should do that and how that's paid for, the European Union has been, I think, making good investments in education programs that can be used across Europe, and of course now in a world of automatic translation as well. So you can have educational programs developed at a modest, reasonable cost by professional societies, and usable in any country, no matter how big or small, and even actually beyond the European Union. So that's a sort of well worth spending what are reasonably small amounts of money by European Union budget levels into education programs.
Yeah, and I think picking up a point you made earlier about digital health and thinking about William's exercise looking at Asia, and then suggesting that we needed to see more of his sort of research in Latin America and North America and Africa. I mean, we always believe at ESH Alliance that, you know, no country or continent's got a monopoly of innovation or good ideas. And the reality is that there must be opportunities here for learning from anywhere in the world, and some opportunities in the developing world to actually not have the legacy systems problems, but to be able to jump into the latest technology and create that. But that's where I think William's blueprint for what does a good immunization information system look like becomes really important. But if I can turn us to the question of picking up something that Marius was talking about, which was the social determinants of health. But let's switch it to information as a determinant of health, and whether in relation to vaccination information systems, we think there's benefit from information and seeing that used. And do we agree with that? And it sort of picks up the health literacy point that one or two of you have already made. So information as a determinant of health, what do we think? Silence.
Maybe I can add something, especially in relation with large language models, and I think we are now in more or less the same point where we were 20 plus years ago with Google And my hope is actually that Dr. GPT to be a better doctor than Dr. Google, right? And this is a challenge because large language models are so powerful. But if you look from a social determinants perspective, actually the data used by the majority of LLMs to be trained are actually coming from Western European countries, actually, by very, very few countries. And to your point, Bledin, so if a person in, I don't know, in Bulgaria, in a village, if they start looking to ChatGPT or Copilot and asking questions about HPV vaccination, the answers are actually informed by the data from, I don't know, Netherlands, from England, from US, from Canada. So the idea is actually to fine tune and to move forward with the development of the large language models through the inclusion of data relevant for a specific country, region, village, or community. So this is a challenge because if we'll not go in this direction, actually the digital divide will increase. But it's an opportunity because if we'll start doing things, we'll be, I think, in a great position actually to really tackle the inequalities.
And I think perhaps turning to a last subject for us, when we talk about the collection of data and its dissemination, we know that there are substantial variations in practices. William, I think from your perspective, what does best practice look like on a local and national level, and the best use of data from an immunization information system perspective?
So it's kind of a broad question, and I've probably got a minute, so I'll just pick, maybe I'll compare and contrast two countries, right? And just to try and picture or to frame an answer to your question. If I take Denmark, right, we know that Denmark is way up in the green space. And no matter, any reports that I've seen in this area, they're always seen as one of the benchmarks, right? And they publish data very regularly, very low latency on the data. But the dashboards that they were pushing out weren't exactly the most usable dashboards. They were a little bit dated. So we took that information, put that into modern dashboards, and then started going to some other markets. And one of them was Slovakia. Now, Slovakia was not, if you went back to our report, was in the red space. But working with a coalition on the ground there, we looked at what data they did have, and they had a national immunization plan which had primary cohorts which were reimbursed, and the insurance data was there at a pretty granular level, which we were then able to use as a proxy for vaccination coverage rates to build a dashboard, which we then worked with the data science unit of the MOH, and they took that over and have been publishing that, and are publishing very strong dashboards on this information. I think one of the things about defining what good is, which is what we tried to do in our report, is one thing. Defining how you get there is the other thing. So it can take years to build out EVORs, and they can be very expensive. Well, that's a long time to wait for having a strong monitoring and so on. And I think this is a really pertinent topic that, unfortunately, we're out of time, Bledin, but it's something that I feel very strongly is something that should be looked into.
That's incredibly helpful, actually. And that point about time and cost and who makes that investment is a challenge, I recognize. So I think we're concluding the panel now. I just like to say a big thank you to Marius, to Trenton, to Richard, and to William, as well as to MSD, who facilitated and supported this particular panel. So thank you all very much.
Thank you, Bledin.
Thank you.